Good morning, everyone. Hopefully everybody's here for the session on adapting the evidence base to local conditions and to different sociocultural contexts. My name is Dina Deligiorgis, and I am the Knowledge Management Specialist at UN Women. My role largely revolves around bringing together the evidence base and the knowledge on what works to address violence against women and girls in different contexts, and provide guidance, programming guidance for program implementers in country for how to work with different sectors. This is a multi-sectoral issue. How to work with different groups, working with men and boys, for example, on this issue. How to implement specific interventions like creating safe urban spaces. And largely this emerging area now of prevention we're looking at very closely, and it is a very emerging area for the intimate partner violence, sexual assault, harassment, stalking. I will be serving today as the facilitator for this session, and Mark, who you all know, will be the rapporteur and will also be co-facilitating with me. Hopefully everybody's had a chance to read the case study, which may or may not help us in answering the questions that are set out before us. What we're going to do is I'm going to ask in a minute for one or more of you to maybe summarize some key points from the case study, what forms of violence were reported in the case study, what some of the interventions that have been put in place were, just for all of us to be up to speed. And but before we do that, what I'd like to do is actually read the questions that we're going to be asked to do some thinking about. The first is...
Dina?
Yes?
Maybe just, if we can go around the room really fast.
And have everyone
introduce yourself, where you're from. I think we'll get an idea of who we have as resources and who we are. But again, we don't have 5 minutes for everyone to give a story, but let's see if we can get around fast.
Sounds good.
You need to press the red light on your microphone.
Good morning, everyone. My name is Kaylin Crockett, and I'm a program specialist in the Family Violence Prevention and Services Program in the Department of Health and Human Services.
Good morning. I'm Susan Pazlusny. I'm an associate professor in nursing at the University of South Carolina.
Good morning, everyone. I'm Sine Kukutuma. I'm associate professor in nursing at University of Cape Town, South Africa.
Good morning. I'm Laura Van Vuren. I'm a senior advisor for HIV at Medical Teams International.
Yes, good afternoon or still morning? Okay, good morning, everyone. I'm Commander Marisa Wright, and I'm with the Health Resources and Services Administration, Office of Women's Health.
Member of the Global Forum, and I'm a professor at the University of Michigan.
Hello, my name is Beth Nagy, and I'm from Massachusetts Department of Public Health.
Hi, I'm Keiko Fujita from Japan. I'm faculty of university in Japan, and I studied domestic violence, so I'm visit here. Thank you.
I'm Michael Phillips from the Shanghai Mental Health Center.
Hi, I'm Maria Valenti. I direct the Aiming for Prevention program for international physicians for the prevention of nuclear war. I work with affiliates in 63 different countries, primarily in the global south.
Hi, I'm Barbara Moynihan. I'm a professor at Quinnipiac University in Connecticut, and currently developing an initiative on human trafficking, which I was hoping we could talk about today, but next time.
Alessandra Scalmati, I'm a psychiatrist. I work at Montefiore Hospital in the Bronx with a lot of victims of violence.
Ivan Juzang, Me Productions, health communications, and marketing.
Hi, I'm Chuchuranwachi Saunders. I'm a pediatrician and medical epidemiologist, but a private consultant that lives here in Maryland.
I'm Jessica Izquierdo. I work with Child Fund International, and I focus on adolescent sexual and reproductive health and gender-based violence.
Okay, thank you. I'm Frances Ash Goins. I'm Deputy Director for the Office on Women's Health at the Department of Health and Human Services.
Carol Kurzik, President of the Avon Foundation for Women.
Graham Vimpani, Professor of Community, Child and Family Health at the University of Newcastle, Australia, and also Clinical Advisor to the New South Wales Ministry of Health on Child Protection and Wellbeing.
Hello, I'm Patrick Kelly. I direct the Board on Global Health here at the Institute of Medicine.
Hello, I'm Marco Ambrosio. I'm the Health Innovations Officer for Sapient. We're a digital communications and technology firm.
I'm Susan Hillis. I'm a Senior Advisor for Global Health at the CDC.
Xing Qidong, Foreign Member and Geriatrician Epidemiologist.
Laura Krause. I work in advocacy and public policy with Catholic Health Initiatives.
Tammy Mam. I'm president of a community-based organization called the Campagna Center in the city of Alexandria, right across the river.
Hi, I'm Nicole Bennett. I'm a fellow with the Office of Adolescent Health at HHS.
I'm Nan Stein at Wellesley College, the Center for Research on Women.
I'm Kathy Ward. I'm based at the University of Cape Town, and Sine Duma and I are both part of our Safety and Violence Initiative. It's a research initiative at UCT.
Hello, I'm Mark Bellis. I'm Professor of Public Health at John Moores University Centre for Public Health, which is a WHO collaborating centre for violence prevention.
I'm Melissa Simon. I'm an obstetrician gynecologist at Northwestern University and a fellow here at IOM.
My name is Teresa Brockie. I am a member of the White Clay Nation from the Fort Belknap Indian Reservation in Montana, and I'm currently a research nurse specialist at the NIH Clinical Center.
I'm Patrick Tolan. I'm at the University of Virginia, where I direct a center called Youth Next, which is focused on positive youth development.
Great, thank you so much. We obviously have very diverse and rich resources in the room, so this should prove to be a very interesting discussion. We also have a lot of food for thought from this morning's presentations that will clearly feed into what we're discussing here today about adaptation.
And I guess I would just add, wow, this is an amazing, amazing group. And I think in adapting programs to local circumstances, one of the big challenges is how do you use the people who represent diverse perspectives, diverse experiences, diverse organizations, beliefs, attitudes, and how do you pull that in? How do you understand? How do you assess the capacity of everybody to contribute to what you're working on? And one of the barriers that you frequently have to get over in adapting to local conditions is just how do you come to understand everybody who's with you? How do you take that time to give them a chance to participate and contribute? But this is quite an amazing group. That's the only observation I wanted to add here.
Thanks, Mark. So what I'll do is just briefly go over the questions, since we will have to report back on these. However, I think there's also value if there are other points that we're raising that we want to reflect in the report out, that there's room and space for that as well. So keep that in mind. The first is decision-making around adaptation. When is it appropriate? When is it necessary? How does one decide what adaptation is necessary? These are things we should think about. The second is much more specific about taking an evidence-based program from the United States that we might be familiar with and seeing how it could be adapted to the case study that we've been seeing. The third point is, what are some of the relevant challenges to adaptation? And again, we've discussed a little bit about that this morning, and there are many. What training and technical assistance is needed, and by whom? A very important question. And again, the human resource element to adaptation, and how, as Mark very eloquently stated, how do you bring along the people? We spoke a little bit about the how this morning and how important the how of implementation is and not just the what is being implemented. And finally, what some strategies for adaptation of evidence-based programs for local conditions and needs are. What are some of these strategies? How would everybody like to proceed? We can either take the questions one by one, or maybe we can have a more organic discussion that will pull out many of these points.
Maybe it might be useful just for you to give a tiny vignette and remind people of the setting.
Oh,
that
in fact,
gives us the cultural context
in fact,
for this.
that was on the agenda to actually have some of the participants from the audience give us a feel for the case study, some of the forms of violence that are being discussed, the context within which they're taking place. And I know there's very minimal information on what kind of interventions were tried, but if anybody would like to volunteer to give a little bit of that information for the group. Wonderful.
I didn't really see much on interventions other than a few laws that were passed. But I have worked with our affiliate in Kenya, and Nairobi is a city that is considered quite dangerous. If you've been there, you know that there's a lot of armed guards around, and so there's a huge slum outside of the city called the Kibera, and lots and lots of poverty, issues relating to just the general social determinants of health, lots of young men without jobs, struggling, hanging around, nothing to do, lots of fights, there's a lot of robbery, etc. Quite a high incidence of sexual violence, women coming into the hospital, intimate partner violence, etc. I know there's a lot of gun violence in the pastoral areas in the north, and that's a big issue as well. That's not directly related to Nairobi, but it is because guns come and go. There's a lot of violent and conflict in the surrounding countries as well. So you've got that as an issue. So the case study, as I said, I didn't really see too much on interventions other than some laws that have been passed. But I do know one thing from working with our affiliates in Kenya and Nigeria, Democratic Republic of Congo, etc., that one of the most important things in terms of tackling the violence is to work with the people that are there and get their ideas and solicit their involvement, because without that, it's very difficult to become involved in the culture, to have anything that's sustainable. So, yeah, I think that's about all I have for the case, but there's a comment over next to me.
Thank you, Arlene. That was brilliant. I think that summarized the case study fairly well. If anybody would like to add anything.
Yeah, I haven't been there, but I've been to Nicaragua and took student nurses with me. And we had 100 women and children waiting for us at a clinic. And we had 2 physicians with us. And this is the theme for how we're going to do this in Nairobi, in Kenya. And as I was assessing, I knew this woman who came in with a toothache didn't have a toothache at all. It was obvious she had been hit. And as I began to interview her, the physician who spoke Spanish said, "Barbara, come here. Don't ask that question. I said, why not? He said, because she will never be able to come for medical help again.
I'd like to make.
Yes, please.
Might make a suggestion. I don't know how many of you have ever been to Kenya in the room, to Kibera. I was thinking that what might be interesting is if we challenge ourselves. Maybe those of us who've been to Kibera act like we're from Kibera. Those of you who've not, when we pose the questions, maybe we can challenge, we can be the pushback. Because the pushback is what really makes us better and it makes our communities better. So if we don't have that in the room now, we'll all probably lean towards what we feel is comfortable. So I was just wondering if we could do something like that to make it more interesting.
That's a very nice idea. And in fact, there's an evidence base behind approaching things in that way, where brainstorming in and of itself has not been found to be very useful. But when you pit two different sides together, you actually come out with something useful. So how does everybody feel about that? Perhaps? Okay. So again, to summarize, we have poverty, high poverty levels, high unemployment, crime and gun violence, also intimate partner violence and sexual assault. And the only thing that we see in the case study as a response are a police response and legal response. So that kind of sets the stage. We don't know much about what the causes of violence are. We don't know what the risk factors are. Sorry, I see that there are other contributions, 3 contributions. Maybe we can start here.
Thank you, Dina. I think that a very important piece is this, is the cultural belief and the entitlement on the sense of the men, on the part of the men, and then this acceptance of the intimate partner violence on the part of the women. Because even though that may have been a more rural type of understanding or belief, it's definitely carried into Kibera.
And if I can just quickly add to that, you know, we might want to also include social and cultural, because violence against women exists in all parts of the world, and it crosses all kinds of barriers, from income, ethnic. So I think social is also an important element that we might be wanting to consider here. Gender dynamics in particular in each society. Thank you for that.
I just want to point out that HIV is quite prevalent in the region also, and it has a direct connection with what's happening in country and what's happening with the amount of attention that has been brought to that region, not just in Kenya, but the whole region around HIV and its impact. And there have been a lot of researchers that come to the area that bring things in. And sometimes the violence is not one of the parts that the HIV people think about, but it's definitely integral in the interactions with people in their families and in their communities.
And that contribution might actually be very relevant when we think about adapting certain programs, because we do know that in other parts of the world, including on the continent of Africa, there are many interventions that started as public health interventions to prevent HIV and added components on intimate partner violence. So a very relevant contribution. Thank you.
I'm not going to role play just in case someone tunes in and thinks that that's actually the character I am, but alcohol is a massive problem. There are lots of illegal bars. The men are unemployed. They're drinking all the time from early hours in the morning. The culture is one of getting drunk. The levels of drunkenness are related to things like risks of HIV infection as well. And because the alcohol is brewed, particularly in Kibera, illegally, even though Kenya's changed the laws, it's not really had an impact. It's just increased things like bribery. And in terms of adapting programs, it's quite important to think that that's nothing like the alcohol distribution mechanism or even consumption mechanisms or ways that we see in Western or other societies. And the other thing I just raise is, I don't know whether people want to think about this, but it is historically very similar to what's happened in countries like the US and the UK. But we're going back quite a number of years when we had those sorts of problems with recession, massive alcohol consumption, and violence against women and children as a result of that, or partly as a result of that consumption.
Thank you, Mark.
The case history also points out two things that other people mentioned. One, ethnic violence, which sort of is an underlying precipitant that's there that can flare up at any time. And then at election time, so there's a stimulus to the election that sort of spontaneous expands this ongoing underlying sort of violence. And that's important to consider because it affects all types of programs. When are you going in, and how do you deal with ethnic conflicts that are, in many countries, kind of the primary driver of a lot of the underlying violence?
I'd like to comment on Kibera, which is the slum that's named in the case study, and the built environment. Kibera is a massive place, but it's really small in geographic area, and it contains 1 million people. Access to it is actually right in the city of Nairobi, and access to it is down a long road, and then once you're in there, it's very difficult to get to various people's homes. And there's no sewer, sanitation, clean water usually has to be hauled, in large, gallon buckets. And so it's very difficult to access the population for doing any kind of, for example, like a nurse-family partnership type of approach. It would be very difficult to implement in that kind of environment where the most of the abodes or housing is made of tin shacks that are like right on top of each other and surrounded by sewerage, and very little access to food and other kinds of resources that we take for granted here.
Just to give a little pushback on that, the people in Kibera, even though they live under the circumstances that you're defining, and there's a lot of immigration and out-migration, the people are intensely committed to the development of their children, even in these circumstances. And there are some programs that has been mentioned where they do. CDC, for example, has a huge program in Kibera where they basically send people to the homes to check on people. So even though you might think, oh, gee, you couldn't set up a nurse-family partnership, you might be able to set up something a little different, but equally or more effective.
I could respond. I agree. There are lots of groups that have small programs in Kibera to attend to things like HIV prevention, other kinds of health services. It's not easy to get in there, and going through an organization that's already there is probably going to be very helpful.
So far what I'm hearing is that indeed there are different risk factors perhaps that we need to pay attention to, or at least uncover. And there are different contexts that we also need to be considering. Whether it's adapting a program from within Kenya in a different part of the country or bringing it from an outside country. So far we're on the right track with getting to our main topic. Yeah.
I'd like to propose a program. I have to keep pressing. Okay. Kenyan women, so play back and let me know. There was once a phenomenal program in the U.S. I had nothing to do with this, in full disclosure, though I think NIJ may have funded it, and they're my funder, where hairdressers in Memphis were working with women. All kinds of women go to the hairdresser, no matter what your economic status is. And hairdressing can go on in somebody's home, backyard, anything. And the hairdressers were trained to talk to women about the domestic violence that they were experiencing, because they would touch their hair and notice bruises or notice gaps where their hair was missing. And so it became this phenomenal sort of rolling, it just increased the discussion of who was eligible to talk about these issues and who could help you sort of strategize, think about resources. And hairdressing salons of any sort, I mean, doesn't have to be an officially licensed salon, are typically women-only places. Men don't hang out there. They may pick their wife up or their girlfriend or their daughter, but they don't hang out there. It's not like church. It's not like, as you spoke about in Nicaragua, the women, the 100 people waiting there. So I wonder for the Kenyan women here in the room, what you think about this idea of having hairdressers be a sort of entry point.
Well, I can attest that there are many hair salons in Kibera. As you drive through the narrow winding road, and women do go there, and it is a female-only place.
A good spot to talk about these issues?
I think it would be a good place to start.
I also think that hair salons are a place for social organizing, social proactivity, for getting advice around childcare, family issues, and around a myriad of things that go on that women talk about with other women. And if you are a regular in a particular salon because you like the stylist, then then the stylist knows about everything that's going on in your family. And they recognize the importance of keeping your business, within that salon, not talking about it outside of that.
Thank you. I'm going to ask if we can just hold on to that setting that we're talking about, the hair salons. We have roughly 25 minutes. And I know it's a very short time for us to get through some of these discussion items. But what we might want to do is actually start with the second point, because I think that will help us answer some of the other questions. And the question that's posed to us is whether there is a program or programs that we have identified here in the United States that may indeed be applicable to that context, or that can be adapted for the context of, and we want to think beyond just Kibera. Even though Kibera is a large piece in this case study, it's really about Nairobi. So let's keep that in mind. It's not just about the slum area. Are there evidence-based programs from the United States that we think would be adaptable for this context?
I'm not talking about the hair salons, but just in terms of the generally, and come on to the evidence-based programs in a second, but and again, people's views would be important, but my understanding from being there was that the school system has had massive investment into it, with huge changes in literacy. And you can see that between the different generations. So that is a big point of potential intervention, because even from kids from Kibera and Nairobi in general are now attending school. They have literacy skills, and that wasn't there before. So if you're looking for a setting which you could potentially transfer some of the learning from high-income countries, there now is a setting available in Nairobi which there wasn't in the past, and we could think about the sorts of support, the sorts of changing in cultural norms, the sorts of additional development at early stages that could be done through those settings now, which wouldn't have been the case even 10 or 15 years ago.
So I'm going to make a disclaimer here and say that this is a little bit of a role play and not necessarily what I think as a scientist. But I'm sitting and I'm listening, so I'm pretending now I'm a Kenyan woman and I'm sitting in Kibera, and you Americans and this British man want to get away, you want to get rid of alcohol. You're telling me I'm crap at raising my kids, and I need lots of advice, and my man beats me up. Well, frankly, I know all that, and I'll tell you what I need. I need a job, because that'll change my family. And by the way, I actually think my man needs a job more than I do, because it'll get him out of my hair for the rest of the day. And I think that's a factor we're all going to have to contend with when we think about going to places like Kibera.
So perhaps our challenge with this exercise is that there is no single program that we're looking at to adapt for to address these issues. What was alluded to earlier today, and I think is really relevant, is that we know that in prevention you do have to hit multiple pressure points at multiple levels simultaneously. And it's not just about one-off programs, though you also need those programs within the strategies that you're working with. So that's an important point.
Kind of based off of what you two just said, I think that it could be helpful to just switch our perspective and not ask what program could we adapt, but what do we have in our context and what program could fit that context and the resources that we have, such as the school system being built up in that community.
So to your question about what could be tried, and I think you're right, it's got to be a few things. But if you go to East Garfield, Chicago right now, which is on the west side, you have open drug dealing. You even have the police present, but they don't do anything. So you have a lot of these similar kinds of situations. As we've talked to the young people there, what we find is that they're dealing with racism, they're dealing with poverty, they're dealing with police harassment and brutality. They're dealing with these environmental things that we're talking about, same thing in Nairobi. Those aren't going to change. So you're ultimately going to have to focus on stress and trauma. So how do we focus on coping and different ways to cope? I think the whole notion of jobs, dealing with poverty, mentoring to be connected to adults, getting back to some kind of education programs. I mean, it's got to be, like you said, multifaceted, but it's got to be culturally relevant and community-based. And the reason why I say that is a lot of times when we do these interventions, we're taking what I call a literate-based approach, and we're going into oral-based cultures. And we tend to think that, you know, we can just take these models and plop them in there. We don't get buy-in from the community. We don't build credibility. We don't build trust. We don't have authentic access to kind of implement these things because we haven't even done reciprocity in the first place. So I just think that the only way we're going to deal with something as big as Nairobi, where the government is allowing this to happen and knowing this is happening because that's why they're not putting police there, is to say we're not going to be able to change the environment, but how can we help folks deal with stress and trauma and cope differently in an environment that's not going to change?
Yes. I just wanted to point out that a program strategy that would be a very important complement to the notion of having a community that's a safe space for women, with the hairdresser example, to develop an environment where they're comfortable talking about the issue, because of course, as we all know, acknowledging that it is an issue is the first step to addressing it. And something that's been successful but not necessarily evidence-based proof of the success would be engaging men and boys in notions of healthy masculinity, as well as better intervention programs. In the United States, of course, there is a risky sense of how we qualify these programs as evidentiary-based success, but I do want to say that there's got to be an expanded notion of how we qualify evidence, and that really speaks to the heart of cultural context and the importance of adapting to culture, because programs that are funded through the Family Violence Prevention and Services Program that speak to engaging men and boys have been seen to be successful in when they are led by culturally specific community-based organizations and have local buy-in. And
I think part of what I was trying to say earlier with that little role play I was doing is that what we're each doing is we're coming in from our own perspective. So we, some of us know about alcohol interventions or parenting interventions or stress and trauma interventions and all the rest of it. And that's absolutely fine, but I don't think you're going to get very far unless you actually spend some time working with the people that you're trying to help and hearing what they want to do. So, I mean, my first step would in fact not be to choose a program, but to work with folks in, say, Kibera or in Nairobi, key stakeholder interviews, some epidemiological work if it hasn't been done, that kind of thing, to identify where the most pressing needs are, and then to try and find the expertise that might be able to help with the program. Because otherwise we go in with a cookie-cutter approach, and it's inevitable. I mean, my impulse is to say, yes, we need parenting programs in this place because of the broad base of raising a whole population, but actually it may not have traction, and we need to know what people on the ground think and want, and what the risk factors are, the protective factors, what's going on there, and we also need to hear from community leaders and politicians what they would support.
Okay, so starting from the ground up and really doing a situation analysis, bringing in stakeholders, making it very participatory, looking at what data you already have in context to deal with, and then moving to what we know might be effective in some other settings that can be adapted with local participation and buy-in. Okay?
Yes, we ought to look at what currently exists, and what I don't hear, and maybe I just didn't listen, I haven't heard anything about the medical people. there are hospitals, there are nurses there, and nurses are definitely influential. When we talked about bringing something that worked here and then modifying it to see whether it would work there, having done a lot of work myself and looking at making change from within. And I think that people who are sexually assaulted, who are beaten up, who have babies, who have illegal abortions, end up in the medical community, end up in the ER. So why not look at, and we've been involved, I have somebody down in Kenya now actually, and we're going to follow, she's doing police training, we're going to do training of nurses, and I did this not in Nicaragua, but in Barbados, to train people in how to deal with victims of trauma and violence. I mean, we have to look at they go to the hospital, are they just bandaged up and sent right back out again without anybody addressing some of the other needs that they have?
Okay, so diversifying our evidence base to bring in practitioner knowledge and experience. Okay.
Another issue would be an issue of language, because a place like Nairobi there's so many people that have come to Nairobi. We assume that they all speak Swahili, but actually when you get there, you find that people are coming from Somalia and everywhere else. Just starting by developing perhaps messages in different languages, even using just slang where everybody else can understand, would be something to start with, so that there's an understanding of what you want to do with the people. So that would be the first thing that one would perhaps start to look at if you want to adopt whatever program that you want to bring in. If the language cannot, if people cannot understand whether it's a hairdresser or whosoever wants to say, it's impossible.
I think it's worth pointing out in Kenya, there are 42 tribes, and there may be 42 local languages, or probably more. And on top of that, you add on the people from other countries who are displaced or who come there intentionally to live. So the language is a real problem. We may want to, I see we have 15 minutes, and we may want to move. We've been hitting some of the other questions, and these comments and suggestions have been very good, but we may want to focus some of the comments on the specific questions that follow.
So my question is, we've been talking a lot about the conditions that are in Nairobi right now, and we've been talking about the victims, but my question always is about the perpetrators. You know, what types of programs do we have, or are any programs there where we're actually talking to the men, maybe even the young boys, about their perceptions of relationships with women? Because it seems as though, you know, men have the power, so we might be able to get to some of these men to be leaders in their communities, to maybe start helping to address the issue. That may be a focus that we may want to look at too as well.
So maybe if we can more systematically look at the questions before us, and I don't know if we're going to have consensus on this, and especially in the context of previous discussion about fidelity to programs, if we're only talking about program adaptation and adaptation. However, are we thinking that indeed we do need to pay attention to certain local conditions, social, cultural, economic, religious contexts when bringing in an intervention or an approach? If we're not talking about a program, but we're talking about adapting approaches.
Initially, you just have to do a situation analysis. I mean, you can't do anything without a comprehensive situation analysis, qualitative stuff. You know, do these ethnic groups, can you put them together? You know, can you put kids from the same different ethnic groups in a group together, or will they automatically fight? You need to know that before you think of doing any program. I have one other comment about giving hope. I know the sense as well, they have horrible conditions, they're not going to get better, we're just helping them adapt to it. I don't think we should ever start with that as a starting point. The schools, that's a clear improvement. Things have improved, so there is hope. So whatever you're doing, you've got to instill hope and encourage hope, because if you don't have that positive take, people aren't going to buy in. I mean, what am I doing? It's not going to make things any better anyway. You know, this sort of adapt to your horrible conditions, you know, and that's not a good philosophy for starting.
I actually think that just to add on to that, I just think that even though we talk about what horrid conditions they are, these people have a certain sense of resiliency,
Yes.
and they've done some really, really good things, and they have some strengths. And I think if we find those strengths, acknowledge those strengths, build on their strengths, where they have had successes, I think that will do more for helping them deal with this problem than not. Speaking to Marissa, there's a group that I was just Together for Girls. I think people mention a lot, but during the International AIDS Conference, they did a film there, and they were showing how they interacted with some young boys to try to figure out, well, why were they doing it? And they were clueless about why they were doing it. But they were doing it because everybody else was doing it. So it became the thing to do, just like they do here in the States. Kids, one person does it, everybody does it, and so there's no difference. They're just acting out on what they do. But I do think that we need to acknowledge the strengths, acknowledge the resilience, and work from that point. And then my last thing is, the first time I went to the continent, I went to Uganda, and I was just amazed of the resilience around getting kids to go to school. But there still was a problem. You had to pay. You had to pay for your kids to go to school. So if you have little money, you don't pay for kids to go to school. And if the kids are going to school, it's the male that's going to school, not the female. That's why Oprah had to do her own group there. But, so you think about that in relationship too. And that school is not a free thing. You have to pay. And if you're already impoverished, you might use money for other things, not for school.
So again, we're getting back to needing multiple interventions at multiple levels. You have your legal framework, you have your institutions and the structural barriers that might be affecting these. You have risk factors at the individual level, you have relationship issues, basically the ecological model, and you have to look across all of these and move them at the same time. Yes,
and just to add on to that, approaching it in multiple ways, when you have a society, as the case study says, that socializes you as a woman to anticipate and accept and almost welcome as a sign of love domestic violence, I think it's also helpful to add in a communications element and take some of the communications campaigns that have been successful in similar countries like India, with some of the same sociological and demographic characteristics of poverty and racism, and find ways to try and use men, for example, to just start to change the societal attitudes and acceptance, especially of partner violence.
Yes.
Well, at the risk of confusing this more, but in thinking about the next questions, it seems to me rather than looking at it as what can we take and adapt, we should be starting from there. And people have been saying similar things like an institutional analysis, etc. But I think it really has to start from there, and we have to just listen and say, gee, have we ever heard of anything that might help, but not have something that we have, and then say, how can we adapt it? Because culturally, as we just heard, there's such a difference that many of the things we would say are proven here just don't meet. So I'm wondering whether it needs to be upside down or whether it is upside down.
And maybe we can think about that, though, also in the context of where, promising primary prevention work is based on things like social theories or scientific theories, and whether there's value in at least using some of the principles and some of the underlying theories in approaching prevention and then working within a local context to develop them further, but still using the evidence base around certain theories and how they're used in prevention work. Other comments?
Yeah, I just wanted to follow on that and also pick up on what someone else said about mentoring and some of the institutions that haven't been mentioned yet or social networks like sports, which is huge in these countries, in soccer, for example. So combining something like mentoring with supporting sports teams. So short of giving young men a job, if they can't have that, some of the physicians that I work with actually personally sponsor sports teams to keep young men occupied and off the streets. Then they develop mentoring programs so that they mentor younger kids. So they're small, personal individual programs, but here they are, and they're also bringing in the faith communities, which are also really important. So they're combining all of those things. And so starting with what's working in those communities makes a lot more sense to me than looking at evidence-based programs here and trying to determine what we can transfer, because all day yesterday, all we heard was we have no evidence of any of the programs being translatable at this time. So
because we are running out of time, we really haven't talked too much about the challenges. Some of that did come out earlier in the presentations, but maybe that's something that we might want to touch on a little bit.
I think one of the challenges is that it looks like 10% of the population is orphaned, and whether they're outside of family care or inside of any kind of surrogate family care, and do they fall within any institution's purview, or are they relatively hidden, both within family structure, within the institutional ones?
So a challenge being within which jurisdiction you can even begin to intervene.
I think maybe the last forum you had was on the contagion of violence. And so if you want to interrupt the transgenerational impacts, you're going to have to begin at the most high risk young people. And that clearly, from other information we have, should be that population.
Okay, so that adds to our discussion of segmenting the population, your target groups, knowing what forms of violence exist, what the different risk factors are for those different forms, and tailoring maybe strategies to different groups in different settings using participatory methods. Is that summing up a little bit about what we've been talking about? Yes.
Let me add one of the areas. If you read, there was a story in the New York Times yesterday, you may have seen, about rape in India. And it said that the police are not your friend if you're the victim of a sexual assault or abuse or rape in India, but very often the police return a woman seeking help to the aggressor and tells the aggressor, this woman came to us to report on you, take care of her. And I think there's been talk that you need to assess the institutional supports that you have, and it may be in doing a situational analysis, one of the things that you need to pay attention to are the institutions and organizations around that we traditionally think of as partners in our interventions. And it may be just as if you tried to take an intimate partner violence program to the police in India, it might be just as bad to try and take it to the police in Nairobi. In addition, there are all sorts of intertribal rivalries and hostilities, and not only might they not talk to each other, but you might not be able to get help from one tribal police person for another community. The whole community at large may not be served by them. And people mentioned the elections, and it may be that the priorities of the police or the national institutions are just not to focus on intimate partner violence at this time. If they're geared up to try and cover up any or prevent any election-related violence because the world is going to be looking at that and their economy is going to be more dependent on that, then this may really get pushed low or totally outside the sphere of their interests, and they may not be willing participants. So just thinking about the institutions that are available to participate, they may be very, very different from what we assume is there as an infrastructure in importing a program from a country like the US to Nairobi.
Also building on the existing infrastructure of institutions. And one thing we haven't really discussed is, where do people naturally go for shelter or for help? And one thing to explore would certainly be the faith communities, because they they are sort of apolitical, and they do have widespread access points. But yeah, in addition, thinking about who the decision makers are in this community, who holds the power ultimately to change to transform, really, this community.
I think our starting point as part of the situation analysis should not be what are programs that have been developed in high-income countries that might work here that we have lots of data on. It should be to look at other countries in low-middle countries that have similar situations and the kind of programs that maybe don't have full RCT studies but seem to be working. And so as an international one, we can go in and say, our situation, here's what the situation is. We know from research around the world that there are other places that have done things for that type of problem. And from there, select those that meet the, you're talking about the theoretical model that we think might, or that fit those standards that we think need to be fit. But rather than select from those programs done in the United States or North America, do programs that have been done elsewhere that seem to be closest to the situation that we have seen here. And the local people probably don't have access to that information, so the internationals can come in and help let them see what's going there and give you, it will provide perhaps a greater chance of success.
I just want to pick up on the point about effectively the structure of the place. I mean, I think there's another direction for violence, which I don't think anybody makes the assumption that people should live in those conditions, and clearly they shouldn't. Violence and describing the problem is an intervention in itself. It's part of the argument for major change in those particular environments. And I think, because we've talked almost as if there's a way of creating an environment where you can create something which is low violence, but still people living in those conditions. I suspect, given strong and supportive parental environments of many people in this room, we'd probably all get quite angry if we ended up living permanently in Kibera. And I think that's a real issue. So part of it is adding our voice to a variety of other voices on communicable disease, interpersonal violence, and a whole raft of other things, economic problems and benefits. So that's part of the pressure to change the institutions and the political representation of those individuals.
I know we only have about 2 minutes left, but one of the questions I thought was extremely important was this, the question here on training and technical assistance and who should give it. I think one of the issues is we always tend to talk about training and technical assistance versus capacity building. And I think capacity building is most important. And I always believe, as some of the individuals here have already spoken about, that there are those resilient factors within the community. There are those, what my father used to teach me, there's always order in the midst of chaos. And so that capacity building, and by whom, it should definitely be done, and it should be done by the people there or people that are closest to them. There could be other Africans who come in and do it, and specifically Africans who understand what it is we want them to do, as well as what it is that they are dealing with from a perspective. Though I think those are the best individuals. So I wanted us to get that in as well.
Thank you. Yeah. Any other comments, contributions? Yes.
Hi there. I just wanted to mention real quick, since it hadn't been brought up, but this idea of unanticipated consequences, which it relates a little bit to what Mark was speaking about with this idea of women going to police officers. You think it's a relatively safe and efficient mechanism for being able to pursue perpetrators and so on. In Kenya, probably the best example I can give is this last year, when we had huge increases in violence against women, we also found that there was an increase in violence against men in the response to the violence they had experienced from their partner. So this for me is just a way to understand, when we're looking at adaptation, when we're looking at how to apply those social ecological theories and frameworks, to understand either historically through our situation assessments or otherwise, you know, what are some of these outcomes or consequences that have either occurred in the past or could potentially occur in the future. And obviously unanticipated gives the the idea that we can't anticipate it, but.
I think the other people are going to be coming back in at 12:15, so we're at the time now. I don't know, Dina, if you want to kind of summarize it. It's been very, very helpful, the suggestions. Clearly, one of the things that strikes me is that the very idea of bringing in an evidence-based intervention from someplace else and just saying, okay, I've got what I'm going to do, and now how do I do it? How do I have to translate it or make little changes, little tweaks? That very idea is something that probably doesn't make sense. And so we've heard a lot of suggestions for how to improve on that. And just having an intervention that is evidence-based, that was proven in one place at one time, doesn't give you very much likelihood of success in trying to translate that into a place that could be so totally different. And that starting that might
the evidence-based stuff
be
might
wrong.
give you the theoretical basis, the kind of issues that you need to address, rather than the methods of addressing the issues. Things that have worked, you sort of the elements underneath it that have allowed it to work are things that might be principles that can be widely applied, but not the specific methods.
And it's interesting that we use evidence not to clarify principles, but as was mentioned today, we usually use evidence to validate specific programs or projects. And we really need to step back and going into a very, very different place and do a lot more assessment before we're ready to bring a program, even if it is blessed by the evidence, before we bring that in. Dina, you may want to add.
Just one final thought that
Please
occurred
do.
to me based on what you're saying. We're talking about bringing things in. Sometimes observations by the people who are there of external programs inspire them to adapt them themselves. We had a situation in our Global Partnership to End Violence Against Women where we had cross-sector delegations from a variety of countries in South Africa to see a sex trafficking treatment program. And the Liberian delegation was so inspired by that, which we never even anticipated, they went back and replicated it. So sometimes taking people out of their context to see something, you know, that addresses a problem they're experiencing allows them to develop something.
So sharing of knowledge and experiences is also very useful. So we do need to wrap up because others will be coming in, but I wanted to thank everybody. And I think the one thing we have accomplished is that we've completely adapted this session. And we will be reporting back out on something that was much richer. And thank you very much again for your participation.